Okay. Oh, the lights. Atma. Yeah. Okay. I'm just gonna go.
Okay. Good morning, everyone. So Joan, let me open the session today. Thank you. Yes, so I would like to very much welcome Sarah Kittel-Schneider to our morning session. Sarah, she's an adult psychiatrist and professor of developmental psychiatry at the University Hospital of Würzburg at the Department of Psychiatry, Psychotherapy and Psychosomatic Medicine in Germany. And she is, amongst others, the head of the psychiatric mother and father child unit, and one of her research focuses on psychosocial and biological risk factors of perinatal mental disorders. Sarah is a board member of the both national and the International Marseille Society for Perinatal Mental Health, and that's also how we first met. And today she will give a keynote on risk factors and treatment of parental perinatal illness. And we're really happy and grateful to have you with us, Sarah. Welcome, and the floor is yours.
Thank you very much for this very nice introduction. So I try to share my screen. So yeah, it can be seen, right? Yeah, I see it there. Yeah, hopefully the Wi-Fi here is stable, but it looks like this. So yeah, greetings to Iceland. I would have loved to be with you, but still I'm delighted to tell you a bit about risk factors and treatment of parental perinatal mental disorders. So first, my conflict of interest, nothing so much to do with the topic here. Then I first would like to give you a short introduction, then talk a bit more, also present our own data about perinatal depression in mothers and fathers. And then, but I will talk a bit also about like other mental disorders which play an important role in the perinatal period. And then last but not least, I will tell you a bit how we manage and treat those different perinatal mental disorders. So first, mental disorders in the perinatal period are very common. As you know, I think it's the most common are depression and anxiety disorders, but there also are a lot of issues with post-traumatic stress reactions, but you are the expert on that, though I will not tell you about that because you know it like everything already. But there are also other things like, for example, ADHD, attention deficit hyperactivity disorder, which can be an issue if it affects mothers and fathers in the perinatal period. And also things like obsessive compulsive disorder, personality disorders, eating disorders, substance use disorders, and like what's called more severe mental disorders like bipolar affective and schizophrenia, as well as the seldom but very important topic of postpartum psychosis. Today, I will focus, as I said, on depression in the perinatal period because it's one of the most common and it's also one of the best studied perinatal disorders. But then I also will talk a bit about anxiety disorders, ADHD, obsessive compulsive disorder, as well as bipolar schizophrenia and the postpartum psychosis, because yeah, as you can see here, those are also among the most common and also treated with medication quite regularly. So why is it important to treat and diagnose perinatal mental disorders? The frequency in the perinatal period is not higher than usual, but women who were previously mentally healthy often has their first manifestation in the perinatal period of a certain disorder. Also, the stigma in this particular phase is even greater than usual. For example, a woman who has become pregnant, she was healthy before, and then she falls ill with depression and pregnancy or the postpartum period. And like the problem is the women blame themselves, so they also cannot understand why they're not happy. They have a child after all, and there's also a lot of a lack of understanding from the environment, especially in this period. And also men experience an even more severe role conflict, because like in most cultures, the man, the father, should like provide for his family, be a strong one, like support the woman. And then when men also experience depression in the perinatal period, and it's even more severe for them, or even a more severe problem with their role conflict. And the other thing is that, and that is also why I'm here talking today, that even like other professionals like obstetricians or midwives or family doctors or psychiatrists, pediatricians, they're also not really like up to date or aware of the possibilities of also treating those disorders, for example, with medication. And the most important thing is that mental illness of both parents in the perinatal period can have severely effects and negative effects and consequences of the development of the children. So we try to diagnose and treat them as early as possible, also to save the children, or to reduce the potential negative impact on the children's development. So there's increasing knowledge about perinatal mental health, but as you can see here, there's a lot more studies published about mothers than fathers. The studies about mothers, maternal, perinatal mental health, so the blue ones, the dark blue ones, and about the fathers, it's the light blue ones. You can see here, there are increasing numbers of studies, but it's still much less studied in the fathers. And I just wanted to make clear that when I'm talking about perinatal period, I mean the wider definition of the perinatal period or the peripartum, I mean from the pregnancy to 12-month postpartum. So perinatal depression, there is a lot of overlap with the symptoms like depression and other phases of life. For example, the core symptoms, depressed mood, then loss of energy or motivation and loss of interest are like the same, similar than in other phases of life. But there are also some specifics in the perinatal period. For example, that the mothers or also the fathers fear that they are not able to take good care of the child, and they are often scared to being alone with the child because they could somehow harm it or something. There's feelings of insufficiency as a mother, or lack of motherly or fatherly feelings. There's a lot of feelings of guilt and self-reproach, and it can happen that a perinatal depression also is associated with an attachment delay to the child or bonding disorders to the child. Also, in a very severe depression, the mother can have ambivalent feelings towards the child, so she's not sure if that was a good choice to get pregnant and to get a child, and yeah, and she's also then again feeling guilty of those thoughts. In the more severe cases, also in psychotic depression, there can occur suicidal ideation, suicidal thoughts, and also, even if it's rare, but we always need to talk about that to the parents and to the patients, if there are thoughts of infanticide, if there are thoughts of actually harming the children. Because as I said, it's rare, but it's very severe if it's there, and we need to talk about that. And also, if it's there, the people usually they like to talk about it because they also feel guilty about that, and then we can see how we can handle that situation. There are multiple risk factors known already for perinatal depression, as well in the fathers as in the mothers. If, for example, mother is depressed, then also her partner has an increased risk of postnatal depression. If the mothers or becoming mothers, the women have increased anxiety and depressive symptoms in pregnancy already, then they have a high risk of getting a postpartum depression. If there's a history of pre-existing mental disorder, as well in mothers as in fathers, that those parents are at an elevated risk. And then there are financial problems, as stressful life events, low social support, low income, quality of partnership. People with a migration background are at increased risk, and then especially pregnancy and birth complications. There's good and replicated evidence that parents of preterm children have an elevated risk of perinatal or postpartum depression. Sleep deficit plays a role. I mean, you can't avoid sleep deficit in the postpartum period, but if it's a really big issue, then that increases the risk of depression. And there are also hormonal and genetic factors, but I will come to that later also in our own data. There are other diagnoses which can occur in the perinatal period and which can kind of mimic depression, or there are overlapping symptoms with depression. The first and important thing, I think, it's the so-called baby blues, which is due to the decrease in hormones after birth of a baby, and it makes like a lot of women just feel a bit like they could cry a lot, but it's different. For example, patients of mine who had pre-existing depression and then had the experience of baby blues, they said they could really distinguish baby blues from depression, because you feel a bit like you would cry, and you have a bit like mood swings, feel a bit unstable, but you don't have what you have in depression, like really negative thoughts and thoughts of guilt, no feelings for your baby or something like this, and that doesn't occur in baby blues. But still, in the individual case, it's not always too easy to distinguish it. So before really diagnosing a postpartum depression, we need to wait a few days and see how the mood develops and how the symptoms develop, and if more symptoms of depression will occur in the individual. Then we have something called adjustment disorder, and this is also not easy to distinguish, because we have those women, they give birth and they really feel like bad, they have a bad mood, they have problems with bonding to the children, and they cry a lot, and they can't sleep. And so we think it looks like an acute postpartum depression, but some of those women, they remit very rapidly, and they have a very good and rapid response to psychotherapy intervention or small dosages of antidepressants, and then they will be fine like after 3 to 4 weeks maximum. And this is something very interesting. I think we need to do a lot more research in the trajectories of like depressive symptoms after birth, because it can be a really severe postpartum depression which needs intensive treatment, or it can be baby blues, or it can be something like adjustment disorder, which doesn't need a very intensive treatment and also not so much medication, for example. But it's not really, we don't have the possibility to really distinguish it at the moment, or predict it at the moment. Then postpartum psychosis can also start with impaired and sad mood, but then those patients very rapidly develop other symptoms. I will come to that later. Then post-traumatic stress reactions, again, also their depressed mood can occur, but then also the other symptoms, like being hypervigilant or having flashbacks or nightmares, and it's also associated with the traumatic situation. But yeah, this is your area of expertise here. Then there are also somatic problems that can occur, or then also mimic depressive symptoms like hypothyroidism, which some women have in labor. We need to check that by taking the blood and see for the thyroid values. Then there can be iron deficiency or anemia after a complicated birth, when the women lose a lot of blood, and this also can occur a bit like to look like, or can look like depression. And there is also attachment or bonding problems or disorders to the child without a comorbid depression. It's more rare. Usually it's kind of associated or co-occurring, but it can be only bonding disorder without another mental issue. And as well, anxiety as obsessive compulsive disorders, often comorbid with depression, and then we need to find out what was first. Was it the anxiety or the OCD, or was it the depression? But they can often co-occur, and then we need to try to treat both problems. So when we have a pre-existing depression, then often is the question, should we stay and continue the antidepressant medication? So the relapse rate in pregnancy is not that high. It's about 9 to 10%. But the relapse rate after giving birth in the postpartum period is very high, especially if you discontinue the medication. So there's one study showing that women with a pre-existing major depression, if they discontinued the medication, they relapsed nearly in 70% of the cases after birth, versus only about 30% of the cases that continued the medication. So still there is not no risk of relapse if you continue the medication, but I think like 70 to 30% speaks a very clear language what we should do with the medication. Also, the women are at risk that have a longer duration of antidepressant treatment, which I think is a proxy for also a more severe disorder. The women who have also psychological or mental comorbidities. And as I told you before, if there are depressive symptoms already during pregnancy, then also the risk of a postpartum depression is very high. So we really should look out for those women and start screening in the pregnancy already, and then also treat them to reduce the risk of relapse. We have investigated in our pilot study couples we started in pregnancy, recruited them in pregnancy. We then finally could analyze 81 couples, mothers and fathers, and I just brought you here the socio-demographic data of our sample. So there were, like, most of them had higher academic degrees. We had some of them had already a history of major depression. And then our focus was more on the fathers here, but because the mothers, or the depression in the mothers, is also one of the most replicated and maybe most important risk factors for the fathers, we included the mothers as well and studied them as well as the fathers. And one a bit maybe a bit funny thing you see here, we also asked them about the subjective perception of the birth. And as you see here, that most of the fathers who were also present at birth said it was very good. And the mothers were more like exhausting or even overwhelming. But I think that was really interesting to see how different is the perception of the actual birth, like in mothers and fathers. But you see here, it was also most of them had a spontaneous birth, and in most of the cases it was the first child, just to get an idea of our sample. And we screened for depressive symptoms using the Edinburgh Postnatal Depression Scale, which is one of the most commonly used screening tools, even if it's not perfect, but I won't go into details about that. And then also we aimed at also look at them and give them a really a clinical diagnosis, and we used the Montgomery Aspect Depression Scale interview as well. And as you can see here, the postnatal depression or postnatal depressive symptoms is much more common in the mothers, using here the EPDS, but it's also present in the fathers. And then we, as I said, we try to give them a real more clinical diagnosis of depression. We used the mattress interview. We included the sleep item, but then also we excluded the sleep item because if you include the sleep item, you have, for example, in the mothers, 3 months postpartum, you have a nearly double as high rate of depressive mothers. So this is not, with a sleep item, it's not the perfect tool, but without you can use it much better. And what was also interesting here in our study, that using the EPDS and the MADRS correlated quite nicely in the mothers. So we have like similar rates of mothers who were like above the cutoff of being depressed, using like both the screening and the interview, but it was different in the fathers. So we had different rates using the EPDS than we had using the MADRS, which also others have found that maybe the EPDS in fathers is measuring a bit something psychopathological different than depression. Maybe it's more about like worrying, because the right here also after 12 months in the fathers with the EPDS was much higher with the MADRS, and you see it's also a bit of a different rates from the pregnancy to the 1 year after birth. But this is something we need to look more into and see if we need to develop a different screening tool, especially for the fathers in the perinatal period. And then, as I said, the depressive symptoms measured by the MADRS also correlated between men and women, which means that if one of the partners is depressed, then it is a higher risk of the other partner also to develop depression. And then what we also measured was partnership quality, and we could also find out, like others have before, that if there is also like the partnership quality decreases after birth. That was in the whole sample, but then it was also significantly correlated with depressive symptoms. So the impaired the partnership was, the higher were the depressive symptoms. And we had some fathers with a history of depression. They also had a higher risk of developing then postpartum depression compared with the fathers without depression in the history. And we also found out that fathers and mothers that were unemployed at the time of the study or in the pregnancy were also at higher risk of developing depression. And finally, we also looked at the childhood trauma questionnaire. And here we saw as well in the fathers as in the mothers that those parents who had elevated scores for adverse childhood experiences had increased depressive symptoms in the perinatal period. And then, because we were not only interested in the psychosocial risk factors, but we were also interested in the biological risk factors and also how the psychosocial risk factors, also, for example, the childhood treatment and stressful life events interact with biological factors. So we decided first to look at BDNF, which is brain-derived neurotrophic factor. And just to give you a short overview of BDNS in general, there's this Vol66Met genetic polymorphism, which is one of the most studied common risk variants, I think, in mental disorders. And it's rather weakly associated with the risk of mental disorders or disorder symptoms. But we know, and that has been shown repeatedly, that psychosocial stress leads to epigenetic alterations in the BDNF gene. You can see here, for example, hypermethylation in the BDNF gene, which then mostly regards also a bit on the side of the gene you study, can lead to reduced gene activity and reduced gene product expression. And also we studied a sample of major depression and bipolar depression people, not in the perinatal period, but in we were treated in our hospital and healthy controls. And we could also show an increased BDNF gene methylation in major depression and bipolar disorder compared with healthy controls, that also then led to a reduced BDNF protein concentration, and as well the healthy controls and the bipolar people, and as well acute as partially remitted state. So we also then looked at BDNF methylation and BDNF protein levels in our mothers and fathers from our pilot study sample. And most interesting, we could find out, regardless of the depressive symptoms, that the pregnant women, this is the time point here. It's T0 is a pregnancy. The pregnant women had in all studied sites at the gene, we looked for the methylation, had lower gene methylation, which was a bit surprising, but as I said, usually a lowered methylation can lead to a lower, can lead to a more higher gene expression, but at that site we studied a lower methylation rate led to also a lower protein concentration. And this you can then see here. That also in the pregnancy, the women had a lower BDNF protein level, and this then increased again after postpartum. And what we also looked at was correlations between the childhood trauma questionnaires and the gene methylation. And here we also could show correlation in the women during the pregnancy and also in the fathers after the birth of the child. So we then also looked at that risk gene variant, but we couldn't find any association with the risk gene variant with depressive symptoms in our sample, also due to the rather low numbers for genetic studies. And it was a bit unexpected that here the TT allele carriers, which are who are usually thought to be the risk allele carriers of higher risk for depression and also lower BDNF samples, they had higher samples. But here you can also see that there were doubled as many men as women in the TT carriers. So it can be that therefore the BDNF levels were rather higher than lower. But we need to look into that more in detail and need to find out what's going on here. But what we could show, and which was also to expected, also known from previous studies, that the mothers and 3 months postpartum, there was a significant correlation of higher depressive symptoms in the EPDS with lower BDNF concentration. And this is what we usually expect, that in mental disorders, especially also in depression and postpartum depression, lower BDNF levels are connected to higher depressive symptoms. And sometimes there are studies if you treat the patients and also the BDNF levels increase again. But I hope I can show you from this pilot study that it's a very complex multifactorial relationships between the psychosocial risk factors and also the biological factors. And at the moment, we try to further investigate all those bit more complex relationships. And the next thing we did, or what we are analyzing at the moment, is that we also looked at the hormonal changes in the fathers, because we didn't find so much evidence for BDNF playing a role in the fathers, more in the mothers. So now we also analyzed hormones, and what's interesting, we could see here that, for example, the cortisol was significantly higher in pregnancy in the fathers, and then decreased after 3 and here also 6 months compared to pregnancy, whereas the testosterone didn't show any significant changes in the whole sample of the fathers, but the dehydroepiandrosterone that also showed the highest level in the pregnancy of the mother, and then a decrease after 3 and 6 months postpartum. And this, as I said, what the father's levels. And we then also could show that increased depressive symptoms in the pregnancy in the fathers were associated with increased cortisol, as well as increased symptoms in the postpartum period. After 3 months postpartum were associated with lower testosterone in the fathers. So I think this is like the first hints and a very new analysis we did, but I think it's very interesting that we can see there are hormonal changes during the pregnancy of the partner and after 3 and 6 months after birth, also in the father. So it's not just like they think they're like co-pregnant, the fathers, but there really are hormonal changes also in the father, even if it's not that that strongly as in the mothers, but it's still an interesting thing, and we want to look into it more detailed also, which are other factors that that influence those hormonal changes in the fathers. We also looked at the bonding from the father to the child, and here we could find out that the more anxious fathers in the pregnancy had, interestingly, a better attachment to the children 3 months postpartum. And but postpartum, and that was more what we expected, was that increased anxiousness correlated with more rejection and anger toward the child and the fathers, and also, which also has been shown before, higher depression prenatally was associated with poor attachment to the child 3 months postpartum in the father. So therefore, I think we really don't need to forget the fathers, because it's also very important to ask them how they're doing and what's going on with them and what's going on with the bonding to the child, because that also can affect the children if we don't treat that. That was like, yeah, what I wanted to tell you about depression and the risk factors of perinatal depression. Now I would like to give you a short overview of the other mental disorders that are also important but less studied in the perinatal period. The perinatal anxiety disorder, which is like the second like most common mental health issue in perinatal period, they often begin during pregnancy. The fears often refer also to the unborn child, and perinatal fears are also a risk factor for birth complications, like small for gestational age as well as large for gestational age, also prematurity, and also in general worse outcomes. And later in life, it can also relate, or it can lead to behavioral problems in the children. Also, there are studies showing that increased anxiety in mothers may lead to more pain medication and may also lead to more cesarean deliveries. It's also interesting that if a woman is breastfeeding, and I've also seen that myself in my clinical practice, that if she is weaning or stopping breastfeeding, that depression can get worse, and also the anxiety can get worse, and this can also trigger panic attacks. So we should be aware of that and also talk about it if the woman is starting to wean or starting to reduce breastfeeding. And there's a special anxiety disorder in pregnant women, which is called birth anxiety, which is a phobia. And this is also something the obstetricians should ask for and then refer them early enough so that we can do, for example, psychotherapy intervention with those women to reduce the birth anxiety. We sometimes experience is that we get those women get referred to us like 3 days before the birth date, and then we should do like psychotherapy interventions to reduce birth anxiety, which is a bit difficult to do in 3 days. So that it would be good if we could see them much earlier. Then there's perinatal obsessive compulsive disorder. During the pregnancy, we often see thoughts of contamination and then also compulsive washing and cleaning. In the postpartum, the OCD thoughts are often about like harming the child or that others will harm the child. And it can also be an increased urge to disinfect or also wash or control the partner's behavior. But it is important to know that OCD patients do not pose a real acute risk to the children, even if they have obsessive thoughts about harming the children, but they wouldn't do it. On the long term, it can, kind of affect the development of the child. So that's also why we treat it, but it's not that we don't need to fear that they will like kill the child or something. But it's not always easy to distinguish like infanticidal thoughts from obsessive compulsive thoughts. So we really need to speak with those people and look into it. And there are high feelings of shame and guilt, especially if it's about harming the OCD thoughts about harming the child. So you need really to ask about that specifically because there's less frequent spontaneous reports. And those women or men, but mostly seen women, are often of fear, really scared of being alone with the child because they think they really could harm it if no one else is watching. Then perinatal ADHD is something which is of special interest to me, but there's not a lot like studies in this area, even if ADHD is a quite common neurodevelopmental disorder, which occurs in about 3 to 4% of the adults. So we should see a lot of adults or parents with ADHD also in the perinatal period, but it's as I said, it's not much known about that. ADHD is associated with unplanned pregnancies and teenage pregnancies, and there are some few studies showing that maternal ADHD could also be associated with pregnancy and birth complications like preeclampsia, infections, also a higher rate of cesarean section and emergency C-section especially, and higher rates of infants that need to be treated in the neonatal and intensive care. The question is why is that the case? And there are also data, there is data showing that expectant mothers with ADHD show more unhealthy behaviors during the pregnancy, like smoking, drinking alcohol, using illegal drugs, and that kind of things. So we should really educate those women about healthier behaviors in pregnancy. And there's a lot of data about ADHD in the parents and then the older children, like school children or teenagers, but there's very scarce data on early mother-child relationship or interaction in mothers with ADHD. Then the bipolar affective disorder or manic depressive disorder, there we have the problem or the issue that the usual age of onset is teenager or young adults. So the first manic or depressive episode may be postpartum, because usually this also is the same lifespan where that bipolar disorder manifests. In case of a previously known bipolar disorder, we really need to look and care for that woman in the postpartum period, because there's a really high risk of relapse. And the depressive episodes can be also very severe, but usually we have some more time to detect them and then also to treat them. But we really need to look for early manic warning signs and then take rapid action to prevent a full-blown manic episode. Because the problem is that even a depressed mother, they don't feel like they could care for the child, but usually it's still okay and they still can manage. But a manic mother can be a danger to the child. If in a full-blown manic episode, we usually have to separate mother and child and treat the mother and then the hospital as an inpatient. And this is something we would like to avoid if possible. Also, bipolar affective women have an increased risk not only for depressive or manic episodes after giving birth, but also an increase of postpartum psychosis. So as well as I told before, in ADHD and anxiety and OCD, also bipolar women have a high risk of pregnancy and birth complications. And then part of it could be the medication, but the other part also could be the more unhealthy lifestyle during pregnancy they also show. So as I said, then in bipolar disorder and also in women who have already experienced postpartum psychosis in a previous pregnancy, they have a relatively high postpartum relapse risk, but especially high without prophylactic medication. So again, here, as in the women with a major depression or recurrent depression, we have about 66% in a study that had a relapse in the postpartum when they discontinued their mood stabilizing medication, and versus 23% that continued their mood stabilization medication. So There is still, even if you're on medication, we really need to monitor and look closely at those women, but without medication, yeah, nearly 2/3 of them will have a relapse, which is a really high number. So I think, again, it speaks for not discontinuing the medication in pregnancy and postpartum period. The postpartum psychosis, as I said, it can also begin with more like depressed symptoms, but then they show like mood swings, and then the psychotic features like delusions. It's often delusional fear for the child, that the child might be harmed by something evil, something like this. They can have hallucinations. For example, I had a patient, she didn't sleep. This is also, they don't sleep. She didn't sleep like for 3 days. And then she hallucinated like toys at the walls. They show a really disorganized behavior. And also here, there is a risk of altruistic, suicidal, and infanticidal thoughts and ideation. So we really need to look closely at that. In 50% of the cases, this is like occurs in women who have been healthy before. But as I told you, women with pre-existing bipolar disorder or family history of postpartum psychosis are also at risk, and we need to look at them closely, as well as pre-existing schizophrenic or schizoaffective disorders. They also seem to, immune dysregulation might play a role, and it's more often in the first child. But as there are not as many cases, the data is also really scarce on more biological risk factors. The good thing is it's easy to treat. If you recognize it early enough and treat it rapidly, then the prognosis is usually very good. And you can treat it quite well using antipsychotics, and usually they remit in just a few weeks, like completely. Only thing is that it can also be the first episode of a schizophrenia, schizoaffective disorder, a bipolar disorder. Then they need to be treated also for a month or even lifelong. But it can only be a postpartum psychosis as a single event, and then you can also reduce or then also stop the antipsychotic medication after some months. Schizophrenic women also get pregnant. So there are studies showing that about 60% of all schizophrenic women become pregnant, even if they have a bit reduced fertility rates, for example, due to the prolactin increase as a side effect of the medication. Women with schizophrenia have increased risk for unplanned pregnancies. Then they are much less adherent, so they don't go as much to the preventive checkups to see the obstetricians when they're pregnant during their pregnancy. They're less likely to have a constant partner. They also show a lot of unhealthy lifestyles during the pregnancy. They're in need of more medical interventions during birth and labor. And the child have a higher risk of, the children have higher risk of malformations, even independent from the medication. So mostly, I think, also to the unhealthier lifestyles. There's lower APGAR scores in the children, and women with schizophrenia have as impaired in their bonding abilities to the child. The risk of recurrence or relapse here in pregnancy is not increased, but they also have a higher risk of relapse in the postpartum period. But it's probably less than in women with bipolar affective disorder. So I mentioned it before, just a few words. It was not like the real focus of the talk here, but don't forget about the fathers. There's also 5 to 10% perinatal depression in fathers and 5 to 15% perinatal anxiety disorders. There are rare cases of also postpartum psychosis in fathers, which I find is highly interesting, but yeah, we don't know much about that. And there's very scarce data also about OCD, bipolar affective, and schizophrenia fathers. But we think if the father is present and also caring for the child, we really look out for mental illness in the father, because it can also have a negative impact on the development of the children. But also if there's a mentally stable father, they can be important assets to a mentally ill mother in the postnatal period. And so we really should include them from pregnancy on, and also give themselves better opportunities for also prenatal bonding with the children. But also we as professionals really need to talk to them and include them, and not only focus on the mothers, even if the mother for various reasons is also a more important person, but still the father can also be a good help and support, but we need to include him. Just last then to the management of parents with mental health issues. So ideally, if there's pre-existing mental disorders, we would like to talk to them about that when they have, or then the wish or the desire to have children before the woman are actually pregnant, because it should be rather prevention than treatment. And if we have the chance and they come to us even in early pregnancy or before pregnancy, we look at the medication, we assess the individual risks for relapse. We also talk about early warning signs, also together with the partner or other family members. We closely assess the psychiatric history, also to get an idea what has helped before or what didn't help, and how acute episode developed in the past. It's very, very important to evaluate the family support and psychosocial situation. We do a close monitoring during pregnancy and postpartum, and we need to prepare also information for obstetricians and pediatricians. And then also, I mean, this is also the topic here, we need to look that we do everything for a trauma-sensitive delivery and to reduce the risk of birth trauma. And we will also closely support and monitor around the birth and the early postpartum period, especially for the 3 months, because that's the most vulnerable period for relapses. You can treat with medication. In the first trimester, we need to have a look or need to be aware of the risk of malformations. Most antidepressants appear safe with regard to malformation. Exceptions are paroxetine and fluoxetine, but only small increased risk of malformation. The most antipsychotics appear safe. Only risperidone in one study showed also really small increase of malformation risk. The stimulants, methylphenidate and lisdexamfetamine, appear relatively safe, the exception of modafinil. And in the newer studies, we also know now that lithium and lamotrigine as mood stabilizers show only a very slightly increased malformation risk. So it's still, you need to talk about that with the parents, but you still, if someone is stable on lithium and lamotrigine, they should stay on that also in the pregnancy. The only thing is we won't give to also women in childbearing age is valproate, because this really greatly increases the malformation risk and has negative effects on the neurodevelopment, for example, the IQ of the children. So valproate shouldn't be given to any women of childbearing age. And then in the 3rd trimester and around the birth, and we should be careful with benzodiazepines, because they could make a floppy child syndrome with breathing difficulties and less tension in the muscles. So we shouldn't give that if possible. The antidepressants and also antipsychotics and mood stabilizers can be continued. There is a small risk for persistent pulmonary hypertension, which is a more severe side effect in the infant. We need to talk about that with the mothers and fathers, but it's only a really small risk. Luckily have never seen that also in the people we treated. And the stimulants may carry a small increased risk for placental dysfunction, miscarriage, and preterm birth, but it's also not clear if it's really causal to methylphenidate, for example, or if it's causal due to other risk factors. What all psychotropic drugs or psychopharmacological drugs can increase is the risk of neonatal adaptation issues. So the children can be more shaky, jumpy, drinking weakness, and can have pulse and breathing irregularities. But this is usually not life-threatening and self-remitting after a few days. that occurs in about 20 to 30% of the children, and it's definitely increased in exposed versus non-exposed infants. But as I said, it's good. You need to give birth in where it's also a neonatal care unit, but usually it's no big problem for the children, and they're fine after a few days. We think we need to really closely monitor the parents with mental disorders during the pregnancy. We see them depending a bit on their stability, or if you need to adjust medication, or need to adjust or need to do intensive psychotherapy. So the stable ones we see one time in each trimester, and the not so stable ones we see maybe every 4 or even every 2 weeks. We need to psychoeducate them about health promoting behaviors, especially in pregnancy and postpartum. And we do drug level monitoring, because also, won't go into this now due to time reasons, but the antipsychotic and antidepressants, they show, I mean, in the pregnancy they tend to decrease with the levels, also lithium lamotrigine, and then increase again around birth. So you need to be careful and monitor that, and then also adapt the dosages. During postpartum, because that is a really vulnerable period, we should consult them and see them in the maternity clinic directly after birth. And then we usually do weekly telephone or video calls during the first 4 to 6 weeks, because it's the most vulnerable period. And it's always a multidisciplinary treatment approach with as well psychiatrists, as psychologists, and also midwives and psychosocial support, and also in collaboration with obstetricians and pediatricians in the best case. So we write all those informations also down in the pregnancy if possible, and we have a special format for that, because we want to avoid uncertainties in the delivery room. We want to increase the patient's sense of security and control, and this is also part of a trauma-sensitive birth preparation. We want to, like, all people that are around in the multi-professional and interdisciplinary setting need to know all the important information about the mothers or the family around birth. We also encourage them to look for psychosocial support. For example, accepting help from families and friends. In Germany, it's a bit special situation. We can do a lot with like sick leaves or employment bans, and also household help via the health insurance agencies. And we have something that is called early help institutions, which also can support especially families with mental disorders of the parents, or psychosocial impairment. And this is what we talk about, like in a pregnancy, and then make the contacts like from early on. And in more severe cases, or single moms with, for example, schizophrenia disorders, we try to get them to agree that they go and, for example, mother-child housings, so that will be supported, like even especially in the early postnatal period. What we do is also that we try to assess the mother-child or father-child bonding and interaction, and there is something what is called developmental psychology counseling, and it's we do that quite regularly in our patients to promote the parental sensitivity, strengthen the parental role, and also promote the positive parent-child relationship. And this is done by work with video analysis and video feedback together with the moms, and also more often we also do that with fathers and their children. And this is something that is easily learned. Also a lot of midwives, for example, do it in Germany, and then it's very helpful for parents with bonding and interaction problems. Just a few words about breastfeeding. There are no serious adverse effects on breastfed children when you breastfeed with antidepressants. So there's, for example, sertraline, there are a lot of studies now, but also other antidepressants are thought to be relatively safe in breastfeeding. So you can encourage the mothers to breastfeed their child. And also here's a study comparing psychopharmacological medication or children that were exposed in the breastfed period with psychopharmacological medication compared to antibiotic medication. And there were also no severe adverse events or developmental problems in the children exposed to psychopharmacological medication when they were breastfed. And for example, an antipsychotic medication, especially olanzapine and quetiapine, pass very little into the breast milk, but also with risperidone, it's acceptable. And there's just not so much data about the newer atypical antipsychotics. We only wouldn't recommend amisulpride because it's very high in the breast milk, and also clozapine because it's high in the breast milk, and there is a risk of agranulocytosis, which is a severe blood building problem. But also the older ones, there are few data, but it should be okay under good monitoring of the child to breastfeed with them. Valproate, as I said, is contraindicated in pregnancy, but it is okay in breastfeeding because it only passes to a small extent. Lamotrigine passes more, but still there are no adverse effects usually in the breastfed children. Carbamazepine is not good in pregnancy, also increased risk of malformation, but it's okay in breastfeeding. And oxcarbazepine, we also do that, but that's not so much data around here so far. Special case is a bit lithium, but it's okay to breastfeed under lithium, but there's it passes into the breast milk and also into the infant, so we need to check also the infant's blood lithium level, kidneys, thyroid values. So we need to check that. So it's only if really the parents are adherent and also agree that there's blood taking like every 4 weeks, for example, also from the infant. Otherwise, I wouldn't recommend breastfeeding with lithium. Stimulants, just to be short, methylphenidate passes only in small amounts, short half-life, so that's okay. With breastfeeding amphetamine, we wouldn't do that because it has a long half-time, and it also is found in the infants, but usually methylphenidate, yeah, is fine. And the other, we don't have data for atomoxetine and guanfacine. Benzodiazepines, I mean, we shouldn't give them in long term, like anyways. If you use them like acutely and short term, lorazepam and oxazepam are also okay. The women don't have to stop breastfeeding if you use them like only in small amounts and only for a short period of time. But there's also psychotherapy. Here we know a lot about postpartum depression and psychotherapy, or yeah, but more than in the other mental health problems. Cognitive behavioral therapy and IPT are effective in reducing depressive symptoms. For psychodynamic therapy and third wave psychotherapy, they seem to be effective in treating perinatal depression, but there's not so much studies around yet. And we don't know a lot about psychotherapy in the perinatal period with regards to anxiety disorders or the other mental disorders. So there's a really a great need for studies in this area still. In the very severely affected mothers, we can also do electroconvulsive therapy. We hardly need that, but it can be done in life-threatening depression, suicidality, and very severe psychosis. But there are only case reports, but still in the severely affected, this can be an option. Which is what is like safer, and maybe we will use that more in the future. The more modern non-invasive therapies like transcranial magnetic stimulation or transcranial direct current stimulation. There are few first studies showing efficacy in treating perinatal depression, and no side effects with regards to the children. So maybe in the future we will use those interventions more. So to conclude, mental illnesses I think are common as well in mothers as in fathers. We always should assess mental health in mothers and fathers or become pregnant women and their partners. We want to treat it because if it's untreated, it poses a risk also for the development of the children. And I think, as I could show you here, there are many treatment options, including medications, which you can use after individualized risk benefit assessment. And we always should also offer, and that is a bit different, I know, in different countries, but we always should offer also psychosocial support and talk to them about which people or which institutions can help them with a newborn child. So thanks to my team, and now I think it's time for a few questions still.
Thank you very much, Sarah. That was so interesting, very comprehensive, and so much food for thought. So, anyone? Yeah, Jean. There's someone. Just a second, the micro is being passed on.
Yes, that I'll pass it on. So thank you, Sarah, about the nice presentation. Just a small question. I don't know if you can go back to the slides, but the testosterone levels in the fathers, because I found it very interesting that the fathers also, of course, and I do see that in practice. However, from the data, I mean, there were, I think I counted 2 men with 0 testosterone. So they're either not the fathers, because they have to be infertile if they have 0 testosterone. They are IVF, and probably the testosterone is not only during pregnancy, but probably, of course, if they have such a low testosterone, they won't be functioning, and they will be depressed, exactly, because the low testosterone will give them the depression.
Yeah, that is. Yeah, I need to. The thing is that is like I just calculated the data myself a few days back, because it's very new. So I need to look into that. You're totally right. If it's really like 0 testosterone, you saw it right. I just checked that, or if it's maybe due to technical issues, or if that were also, I need to, I have all the like somatic comorbidities and phenotypic data of those fathers, if there's something like really pre-existing in them. But that's a good thought. I mean, in this really like outliers with this even very high or very low levels, we also need to look into the individual data set and see what's going on there. Yeah. But that's a good thing. I need to do that, but I can't answer you the question now if it's what's going on with those men.
In fact, there's John next to me, and what also maybe one thing that if you're going to look at the data again, to distinguish between the total and the free testosterone, because sometimes the free testosterone gives you a better picture.
Yeah.
Than total.
That's totally right, and that was a mass spectrometry measurement. So I only showed like the bit like manually picked metabolites and hormones now, but we have the full range. So we have a lot of the free and and we have also other metabolites measured. So we will analyze that like in a more broad picture. Yes.
Thank you. Thank you.
Okay, I'm going to come up with a question about your childhood trauma questionnaire data that you had. And you saw sort of increased depression risk in mothers and fathers. First question, did you look at the subscales of the CTQ? Was it associated with one of the subscales? But also, we've been looking at this similar data in the ALSPEC cohort, and is the sex of the child a significant co-founder?
Yeah, we looked at the different areas in the CTQ, not only like the sum of the whole score, and it was a bit different in women and men. I didn't go into that in detail. And we also looked at the sex of the children. That didn't affect any of the things we analyzed so far, but I know that from other studies it has been shown. I mean, other study, it's only 80 couples, like 81 couples. So that can also be a reason why not everything came out significant, because like the ALSPEC cohort, they have a lot of more like people in that. Yeah, but the childhood trauma questionnaire, there were differences between the also between women and men, and between the correlation with the depressive symptoms and the subscales. Yes.
Thank you, Sarah, for your interesting talk. I have a question on the BDNF methylation. Did you do the methylation at the promoter of the gene, or did you do the methylation in the core of this gene? Because this could explain the unexpected result that you obtained.
It was exon 1, and it was the promoter. And I know there are studies like on exon 4, for example, that show different results. Yeah, but this was, if I remember correctly, it was exon 1, and it should be the promoter region. Yeah.
Okay, because maybe if you're looking for the other region, because as you know, the methylation change according to the position of the methylation, and in the core of the gene, you can have a different kind of methylation that can explain your unexpected.
Yeah.
It's in the known promoter region. It's the CPGs that everybody looks at.
Yeah.
These are the well-known CPGs in the BDNF promoter.
Ah.
Yeah.
Okay, thank you.
I also have a question. I take the chance while the mic was being passed on. Sarah, I was wondering about the mechanisms. Why is, like, for example, the hair cortisol levels were changing from pregnancy in fathers and then in the postpartum period. Why do you think that is? What happens with them?
I mean, that was not hair cortisol, that was blood cortisol, just to
The cortisol
yeah.
level,
Yeah, I mean, yeah, that is, I mean, I mean, like higher cortisol usually, I mean, you can see that in like acute stress, and then reduced cortisol you can see in more chronic stress, right? So that could be a bit of the explanation, but I mean, we also need to look into that in more detail. We also have more socio-demographic and other variables to compare it with or associated with, but it could be that the pregnancy is like more like they're a bit like acutely stressed and worried, and then the longer it is, like our periods are also, we studied them, and it's more, it's like when the child is born, then it's more getting into like more chronic stress. And then we see that also in for example, ADHD patient, they have a reduced cortisol and compared with controls, but because they are under like chronic stress. But yeah, this could be an explanation.
it's the perinatal stress that the fathers are suffering from. You think that would be the assumption?
Yeah.
Okay. Yes.
Thanks very much, Sarah, for a very, very interesting and very comprehensive presentation. There's lots of things I'd like to ask, but really, I suppose the one thing I would like to know about is, from a midwifery perspective, we find that fathers are not included necessarily throughout the perinatal period. So when you talk about assessing fathers, yes, I think that's very possible where a woman has already had a diagnosis of any of those conditions that you said earlier. But as we all know, there is a very high risk of postnatal depression, particularly anxiety, first-time mothers, new mothers who've never had that, and you said that in your presentation as well. So I suppose from a policy perspective, I would like to see, or has anyone any ideas, or have you any suggestions, because you actually have a good cohort in your study of 80 fathers, which are a kind of hard to reach group in terms of research. But how do we get fathers included in the perinatal period so we can do this research, which is preventative research really, in terms of identifying risk in the antenatal period, to build the psychosocial supports that are necessary, because that's my area of looking at, rather than going down the route of medication, which is what we'll be trying to prevent. So from a policy perspective, how do we get fathers to be engaged? Because they're not seen as patients, they're not seen as part of the woman's journey, even though they're crucial to the woman's support structure around her whole journey. So I just wondered, did you any thoughts on that? Thanks again.
Yeah, that is very important. And it's also, as you said, it's not so easy to like kind of also to we try to do like special support groups and stuff for the fathers, but it's not so easy to get them to really be involved in that. So what we did in this study, I recruited those couples, we call that a parent information evenings that they give at the obstetrics hospitals, and usually they're like in 80%. Also, the father is present, and they are more and more interested. Also, for example, I was really surprised because there were fathers like asking about birth complication rates and all that stuff, and the mother was just, or the expecting mother was sitting like next to her partner, and it was actually the fathers asking very specific questions about birth complications. So I think fathers more and more get really, and they want to get involved. And for example, like this events where you give information and where they choose in which hospital they will give birth, and that is a good way, or that can be something you can recruit them. And then also in this birth preparation courses, at least in Germany, but I think also in Europe, it is common. We need to try to include them, and maybe not with only one appointment, but there are also ideas to make like special, like expecting fathers courses where they can also talk a bit more about their specific topics they have. And the Australian colleagues, they have done a lot more research into fathers, and they have, for example, invented mobile health or mobile information services for expecting, like SMS for dads and something like this. So this is something fathers could like and could get them more involved, also to giving them more information about mental health in the perinatal period, also for not only for their partners but also for themselves. But I agree, it's not easy, and we trying out a lot of things, and I have not the perfect plan of how to get the fathers more involved.
Thank you, Sarah. I'm Sia from Iceland, and thanks for this really interesting and good overview. I do actually agree with you about the fathers. They really, and that's our feeling here in Iceland, they want to be more involved than we maybe allow them or take them with us into this journey. Something we have to work on and look into them, but we don't really have any research on fathers here in Iceland, expectant fathers. But I'm wondering about what is your opinion about including stress in these, with depression and anxiety in this research? I'm thinking about like the depression, anxiety, stress scales.
Yeah, we have what we have included. We haven't just not analyzed it yet. It's called Trier Chronic Stress Inventory. That's a German one, but it measures chronic stress, and it also correlates very good, for example, with cortisol measures. And we have included that. We just need to analyze it yet.
Great.
And then we'll see what comes out for the next publication. Yeah.
Thanks, really exciting to wait about that. But I also have a question about, did you look at bullying as kids or teenager? Have you anything on that?
No, but that is also, I mean, that because you're totally right, the child trauma questionnaire is that's more on the what parents or relatives like did to them when they were like smaller children. But bullying, we know that already from other studies, that bullying is a big risk factor for mental disorders later in life. But no, we haven't asked for that.
Okay, thanks.
Okay, just wanted to pick up on the ticks. You said you'd done the ticks. You've measured cortisol. Are you going to do methylation of the glucocorticoid receptor?
Yeah, if I got funding for doing it, then I would really be interested to do it.
For you.
Oh, that would be cool, because the samples we have a lot of samples just frozen down.
We set the assays up originally. We published them back in 2007, and we got the pyro mark. We'll just sequence them for you.
Yeah. Very nice. Then I will write you an email, or you write me an email.
I'll drop you an email straight away.
That will be cool. Then I can send it over, no problem.
Okay. The other point I wanted to pick up on was the valproate that you had there. You looked at malformations. That's not the risk for valproate. The risk for valproate is autism, because we use it in the lab with rats. You feed pregnant dams valproate all the way through, and it's still effective in inducing autism in the pups, particularly throughout the lactation period. So breastfeeding, I would think saying no as well, not because of the risk of malformations, but because of the risk of
Yeah.
autism.
That is, I mean, the thing is that in my clinical practice, we don't do that because we definitely don't give Valpura to women of reproductive age like anyway. So not in the pregnancy and also not in the postpartum period. But yeah, you're totally right that if there is an exposure of the children, the neurodevelopment can be disturbed in autism. Yeah, I need to include that in the presentation. You're right. That is a risk. So yeah. Totally right.
Are there any comments or questions from the audience online? Okay.
And I have maybe one last question. Since you're also a psychiatrist, like a clinician, I was wondering about the about your, you said you wrote it was a mother and brackets father child unit, right? So do you, I mean, we know that perinatal depression is already stigmatized among mothers. So I was wondering about the patients, the male patients you might treat. How is this coming along? Like how, I mean, I imagine they must have a really high amount of suffering before they would come to your place to get treatment.
Yeah, this is true. But there are increasing numbers of fathers who contact us. It's getting better, but still, yeah, the stigma is even more in the male. There, as I mean, said that the role conflict is even severe. But because this unit, like my co-workers in this unit, is located in the obstetrics department. So, I mean, if, for example, if a child dies or there's preterm birth or complicated birth and birth complications, then we see them like shortly after that, and we see both of them, with the mothers and the fathers, and this is a way to also kind of get hold of the fathers and just treat them like early on. But the other ones who are not giving birth in our department, yeah, this takes them a long time to come. And I had this case, we were really, I don't know, like kind of shocked about it. There was a father with a really severe perinatal depression, postpartum depression. And he was willing, he was referred via like friends and relatives to us, and he was willing to be treated in our outpatient clinic. And then his wife, she didn't allow it. She then like forbade us to be in contact with him. And again, he said, no, he doesn't need treatment. You don't need to contact him again. Don't do that, otherwise I sue you. And so she was withholding treatment for her husband, who were really severely depressed. I've never experienced that before, but this is something that also can happen, obviously. But in general, it gets better, and I think we really need to do a lot of campaigns to reduce the stigma, especially in the fathers. Yeah.
That was a nice ending. Nice last sentence. We totally agree. Any more questions? Yes, Sandra. Okay, one more question. Because
and then I have a few comments for the group before we leave. But
okay, was it for the group? Was not the question. Okay,
thank you, Sarah, for the brilliant lesson. I am a bit concerned about this raising involvement of fathers as patients, just because once, as you said now, there was the stigma about women, and all the involvement of the clinicians and society was on mother or postpartum depression or mother depression. Now, I would like to ask you, if how do you interpret this kind of shifting by the mother, a primary subject and actor in this passage from not having any transformation before pregnancy and after pregnancy, all the pathway, and then after labor and childbirth, and this subtle but not so subtle involvement, progressive involvement of men as father, okay, of course, but men in particular in this particular epoch in which we are living now. You know that there are a lot of men that the men, we are a bit confused as clinicians about binary, non-binary, and also we sometimes we look at this situation like a primary envy of this situation. But in your clinical experience of last years, how do you interpret this request of attention? Not only request of attention, but directly to major clinical pictures, clinical importance of even depression directly. We have as women and the clinical have some ideas, but I would like to ask from you, because anyway is not a strategy but a reality, less attempt to concentrate interest on the primary situation, because is in the woman body, that is more body and mind, obviously, that is acting this process. And it's interesting also the language, expectant father, depression of the father. I don't know, I just want to have your important opinion. Thanks.
I think it's also about what is important. It shouldn't lessen the importance of the moms or the women, because we still have a higher risk of all those disorders, especially depression and anxiety. So it's not the thing that I would like to switch the focus from the mothers or women to the fathers, but I think it's more in the direction of, we need to, as you said, that the society is getting more and more diverse, and there are more non-traditional also families, and also the traditional like roles of the genders are changing, and we should take that into account, and we should go more for the family medicine, you know, like family, like including all the family members into our interventions or into our preventions. I think that is the case, but we will not forget about like the moms. And also, I mean, we are doing another study because we're interested in hormonal changes in women in the cycle, and then also association with effective symptoms and drug levels and all that stuff, because women in general are very understudied in medicine. So I think that, but I think it's not, we want to we want to do like gender, you know, like gender specific, or you know, like a gender focused medicine and gender focused research. I think that is good to include like the whole family and all genders, and to look at them specifically, but not to it's not meant to lessen the importance of the moms and women, definitely.
Thank you, Sarah. That was really, it was so interesting, and thank you for taking the time and joining us. I know you're actually busy today, so you went to another room, so thank you for that. And yeah, so we have some more announcement, but I think first you have to get the proper applause.
I just have a few announcements for the participants, and thank you for everyone who has been online this morning. Remember to sign all the 3 papers outside the room. If you're going to be reimbursed, you have to sign, so remember that. And I was just wondering, do you want me to arrange something for dinner on Friday night? If you could just put your hand up and I could count. Then we have at 6 o'clock, maybe something just light dinner. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, 12, 13 persons. Also, I will let you know about more information 12:13, okay. And whale watching tour, hopefully tonight, hopefully. And is anyone who's missing this one? Okay, it was in my car when I came home yesterday night. I have no idea who has this. But yes, now we should have a light refreshment and hot coffee or tea. And we will see each other again here at 16:15 in this room.
This was the idea, was we didn't have all the working groups all at the same time. Did you see them? Some groups are there, some groups aren't. So that they can do to do the work. Also, this morning, it's because the work was used so that people can go to more than one.
We don't now we can stay to work here on the order. Yes, it's